Good afternoon. I'm Kimberly Northrup from CE Central. I would like to make a few announcements before we start. I have muted everyone's microphone. Please ask questions via the chat function. At the end of the talk, I will read as many of them as I can for Dr. Morehead to answer. I will also display the Get Credit code at the end of the talk and put it in the chat. Dr. Scott Morehead graduated from the Oral Roberts University School of Medicine at Tulsa, completed his internal medicine residency at Emory University, and completed a fellowship in critical care and pulmonary medicine at the University of Alabama, Birmingham. He is currently a professor of medicine and faculty at the University of Kentucky College of Medicine and an attending physician at UK Healthcare. He specializes in pulmonary critical care medicine and pulmonary medicine. Today, Dr. Morehead will give a talk entitled Severe COVID-19 Respiratory Disease. Welcome, Dr. Morehead.
All right. Hello, my name is Scott Morehead. I work here at the University of Kentucky College of Medicine. Today's topic will be severe COVID-19 respiratory disease. I just want to assure everyone that you won't have to look at my face, which is probably advantageous, but I want you to confirm to my superiors that I am wearing a tie and wearing a shirt while I'm giving this lecture. So there we are. The objectives today, after I'm done, I'm hoping you'll be able to assess a patient's risk for severe COVID disease, discuss how to order supplemental oxygen and adjunctive respiratory support, know when and perhaps even how a little bit to intubate a patient with this, outline some ventilator strategies and underpinning pathophysiology, and explain only a few special pharmaceutical considerations relevant to this. Now, there's a caveat I'd like to add. One is, this is a very dynamic and new disorder. There's not a whole lot of randomized controlled trials on anything. And the data and information that is available is coming out daily and it's changing all the time. So some of the studies I'm referenced are preprint. That means they've been submitted to journals. They have not been peer reviewed. And I access most of these via the website medrxiv.org. You may wish to look that over, okay? So I'm going to start with just a local presentation of a case I participated in the care of. A 62-year-old woman presented here at UK hospital. She had a history of hypertension, left ventricular hypertrophy. She had had a week of fatigue, cough, fever, dyspnea, severe watery diarrhea, and emesis with no oral intake for 2 days. She noted that several coworkers of her had recently tested positive for COVID-19. Her vital signs on presentation included a fever of 102.8, pulse is 101, respiration is 23, and the blood pressure was actually elevated at 171/85. Her heart had a regular tachycardia and expiratory wheezes on chest auscultation. Labs revealed a leukocyte count of 6.5 with a normal differential, but her lymphocyte count was reduced. Her BUN and creatinine were elevated, as you might expect from not eating or drinking for 2 days. Chest x-ray, as shown here, was interpreted as questionable patchy opacities, but you can see it's not terribly remarkable. Labs after admission showed that she was COVID-19 positive and actually also strep pneumonia urine antigen positive. She was treated for the latter with ceftriaxone. On the 4th day of hospitalization, she was begun on hydroxychloroquine. She initially required 1 to 2 liters of nasal oxygen, but on that 4th day, later on, she developed severe hypoxemia and she had to be intubated and placed on mechanical ventilation. Just think a little bit about that case. That's from someone here at UK Hospital. So these are some features of a little over 1,000 patients hospitalized in China with COVID. Again, these are hospitalized patients. Remember that approximately 80% of patients who have COVID will have minimal symptoms or mild symptoms, maybe even asymptomatic, and will not require hospitalization for the most part, but these patients did. So in these patients, the mean age was 47 years, less than 1% were less than 15 years of age. And so in general, this is not a pediatric disease, it's an adult disease. Their incubation period was 4 days with interquartile range 2 to 7. So most patients had been 7 days out. Their symptoms, fever was present, but only in 44% or so at presentation. Ultimately, about 90% had it during their hospitalization. About 2/3 had a cough, and only about less than 20% had shortness of breath or dyspnea. GI symptoms were present, but pretty rare in this cohort. Other findings at presentation included an abnormal chest CT scan, including ground glass or bilateral airspace opacification. I'll show you a CT scan of that. The yellow arrows indicate focal or multifocal ground glass opacification. And some of the radiologists have looked at a lot of these studies. And if you see a patient you suspect of this and have multiple rounded multifocal ground glass opacification, that's very consistent with this. Lymphopenia is present, as in our patient, about 83%. And C-reactive protein was elevated in almost every patient. Not 100%, but very high percentages. The outcomes for this group of hospitalized patients, about 6% had got sick, really sick, like went to the ICU, had to be on a ventilator and or died. About, in their cohort, 1.4% died. Again, every published cohort is probably a little bit different, but this is the thing, okay? So deterioration, you know, since we're talking about severe respiratory disease, deterioration usually occurs in the second week of the clinical illness, as again, our patient seemed to conform to. And when they do that, they have a cytokine storm that's been described as. Inflammatory markers go way up, they have increasing hypoxemia, and ultimately usually go to the ICU and or get intubated. This is a paper from Seattle looking at 24 patients who were actually in their ICU for COVID. The mean age of this set was 64 years, so substantially older than the prior case series. And they were obese. The BMI on average was 33. They had had symptoms for 7 days, plus or minus 4, before they were hospitalized. The symptoms were not that much different from the prior group, except that almost 90% had dyspnea or shortness of breath at presentation. That contrasts with 18% in the prior cohort group. These patients have many comorbidities, and we'll get to this a little bit more in a moment. Diabetes mellitus in over 50%, 20% or so had chronic kidney disease. Several of them received corticosteroids for presumed exacerbation of asthma. And here are the outcomes, and they're not terribly good actually in this group. 75% of those going to the ICU required intubation and mechanical ventilation. Over 70% required vasopressors. They were in shock. Almost 40% received paralytics to facilitate mechanical ventilation, and 25% actually had prone ventilation. We'll talk about that later. Half these patients died, and importantly, if you look at that, a lot higher percentage died were older, greater than 65. 62% died who were over 65 years of age versus 37% and less than 65 years of age. But from someone who is, you know, not that young anymore, 37% is not that comforting. And this is probably an underestimate, because at the time of this paper, 3 patients were still on the ventilator. So this could be an underestimation. So when patients with COVID need oxygen, how do you give it and how much should you give? So as a general rule in critical care, we want to give them enough oxygen, but more oxygen than they need is probably not good and actually may be harmful. So our target saturation via pulse oximetry is 92 to 96%. There are some papers below if you wish to read on this. We usually begin with a standard nasal cannula, and using the standard nasal cannula, you can deliver up to 6 liters per minute, but that's the maximum using the standard nasal cannula. I would encourage you, and since we're talking about severe COVID disease, to watch these patients for decreasing saturations and or increasing respiratory rate. When that starts to happen, you need to think about this patient may be getting more ill. There have been numerous reports of COVID-19 patients profoundly desaturating over just hours without apparent respiratory distress. And we'll get to that in a moment, why that is. They've been described as so-called happy hypoxemia. I think Dr. Ham alluded to this last week. When you see a patient like that, these are patients that are likely going to go to the ICU. Very high likelihood of needing to do that. And there are a number of options to oxygenate these patients in this crisis time. So one of them would be a simple non-rebreather mask. That's often correct and helpful. You just need to remember that whenever you do, whatever you do here, you don't want to wait too long to do something more if they need it. And that something more may be in mechanical ventilation. So that's one of the concerns, again, about the non-rebreather mask. You don't want to sit on these patients too long if they're deteriorating. You can proceed to intubation, and that's often the correct answer, although as we've gone along, certain centers like in New York where there's patients that they can't deal with, that may not be the best answer for them early on, because there are concerns over not enough ICU beds or ventilators for that. So you have to make a judgment that is very local and time dependent. Right now, I think we have 10 patients in our hospital. If we had 100, that decision might be altered. High flow nasal oxygen. something we use all the time for other patients in hypoxic respiratory failure. There were initially some concerns with high flow, whether this would generate infectious aerosols. But as, again, things have changed and more dynamic information has come out, most people on balance would consider this for patients with COVID and hypoxemic respiratory failure. And here at UK Healthcare, it is certainly an option to consider. BiPAP or non-invasive ventilation, there are even more concerns about infectious aerosol generation here. And there's also a concern about putting someone on this. They might take very high tidal volumes on BiPAP and actually further injure their lungs. Again, there's no definitive recommendation here. I think we're trying to avoid it where possible. And especially if you were going to consider high flow and especially non-invasive ventilation like BiPAP, you'd want to have these patients in a negative pressure room. And that's all I'll say about that. So here's tracheal intubation. I am not an anesthesiologist, but I have participated in a couple of intubations of COVID patients. So the general idea here is we want to do it quickly to avoid aerosol generation. So we do a rapid sequence procedure with deep sedation and paralytic given quickly. Now this requires, as any intubation does, planning and expertise, but even more than the average intubation. And the reason why it takes more than the average intubation is because these patients are going to profoundly desaturate, especially if we don't bag them after giving the paralytic and sedation. So you need to have the most experienced operator and support staff available. I would strongly consider giving these patients nasal oxygen during the whole procedure, even after you give them 100% by mask and the nasal oxygen. I'd give them both. When you take off the mask to put the tube down, I'd leave them on nasal oxygen during this time. Obviously, you need full PPE, deep sedation and paralytic, and give enough paralytic, typically high dose paralytic. You're going to try to avoid bag mask ventilation, but it's in the image over here on the right shows you, if you're going to do that, you want to use an inline filter, and that's what it looks like to avoid aerosol generation. Now, I want to make a point there. Don't avoid bag mask ventilation. The patient's profoundly desaturating, they're dying. You need to do that. You're wearing PPE and you're in hopefully a negative pressure room. Please don't compromise the patient's health here. We use a video laryngoscope because that on average gives us better first pass success on intubation, but probably more importantly, it moves the face of the operator away from the patient's face where the aerosols are emitted. After you place the tube, you want to directly connect it to the ventilator without bagging if you can. Still use an end-tidal CO2 monitor, and you want to use a hemostat to clamp that tube when you're making that transition both on and off the ventilator, again, to reduce the chance of having infectious aerosols generated. Now, because it's a tricky procedure, you definitely want to have someone, a backup operator, and you want to have backup tools. And here in particular, I'm talking about a laryngeal mask airway, probably a bougie as well. Everything you need in the room, you need to plan these things out. And that's basically all I want to say about it, but I think that's important. So ARDS is the most common cause, or is the cause of most COVID deterioration. I think that's important. When patients with COVID deteriorate, they're deteriorating because they have severe hypoxemia. They've gone from pneumonia typically to ARDS, acute respiratory distress syndrome. This is a paper that was published again this year from China, and this looked at one hospital had 200 cases, looked retrospectively, and what they wanted to look for is, are there factors that may predict the development of ARDS and or death? So in this cohort of patients, of these 200 patients, 42% or so developed ARDS and over 20% died. So this is a little different cohort from the past cohort we showed you. All patients who died were on a ventilator for ARDS. When they analyzed factors associated with development of the severe respiratory problem, these are their factors that came out significant. The parameter is on the left. Hazard ratio for ARDS is in the middle column. These were all statistically significant. As you can see, age is a risk factor, over threefold higher chance of going to the ICU with ARDS for that. Very high, persistently high temperature is another risk factor, almost twofold chance. I will say that about the highest temperature, if the patient is persistently febrile, that is a risk factor for getting ARDS and going to the ICU. But if you have ARDS in your ICU, actually not having a fever is actually probably worse than having a fever once you've had ARDS, because it probably identifies you as having a poor immune system. Hypertension is our index case, almost a twofold increased risk. Diabetes over twofold. And then two lab parameters. The C-reactive protein and serum ferritin were found. C-reactive protein was the most robust factor, almost five-fold chance of going to the ICU for ARDS if you had a high CRP above 5. These are high sensitivity CRPs. So another parameter that's been followed because it's felt to be very important to the hyperinflammatory response that leads to ARDS and hypoxemia is interleukin-6 or IL-6. This is a small study. It's a preprint study from Germany looking at 40 patients that they measured and followed IL-6. And they found that the predictive cut point for IL-6 from either getting ARDS and going to the ICU was 80 picograms per mil. Show you the data right here. Just popped it in. Hopefully you see this. This is on the left side, the IL-6 level at first assessment, then maximum IL-6 level before intubation. And you can see the 80 cut point. That's pretty darn good. Again, small study. Currently at UK Healthcare, it's a send-out test, so I don't know if we can get it back that quickly to make a difference, but I'm not sure about that. So I just want to say that is a parameter that is correlated quite nicely with respiratory failure. Now in this small study, pulse rate, CRP, and LDH also correlated with the development of respiratory failure. So these are factors. All of these factors should be considered when you're thinking about whether this patient's getting sicker or not. So I'm going to talk a little bit about ARDS in general, and then as it relates to COVID specifically. So ARDS is acute and widespread damage to the alveolar capillary membrane. It has to be due to either a direct or indirect cause, classically major trauma and bacterial sepsis, but COVID-19 is what we're talking about today. There's specific injury to this alveolar capillary membrane. On the right-hand side is a diagram I took from a New England Journal of Medicine article. Basically, the large circle here, I don't know if you can see my pointer, is the alveolus. This is the alveolar capillary membrane. What you need to know basically is oxygen comes from the alveolus to the blood, CO2 goes from the blood to the alveolus and is breathed out. That's the way respiration works. And the barrier between the alveolus and the capillary and the little membrane is very fine in health, allowing this exchange of gas. When you get damage to that, that is impaired. And that is why these patients get hypoxemic, because the impairment of that membrane allows leakage of fluid into the lung, the alveolus, and impairs oxygenation. That is the pathophysiology and pathogenesis of ARDS. The Berlin definition, which I include for you here, is not specific to COVID, but it says that you have to have an insult that's fairly acute, that's the A in ARDS, within 1 week or so of the clinical insult or worsening of symptoms, bilateral opacities that are not explained by cardiac failure, volume overload, save from renal failure. And there's a severity criteria. And the severity we use is based on the arterial PO2 over the fraction of inspired O2, or the PF ratio. And so you have mild, moderate, and severe, as you can see there. So ARDS lungs require PEEP. Okay, PEEP is positive index expiratory pressure. At the top here, you can see these are just pathology slides. Top is a normal alveolus. Again, you can see, now the diagram was before. This is just an actual slide showing a very thin alveolar wall with the capillary in that. Look how thin that is. And all the white stuff is the airspace where the air that goes from the environment to the lung and then out again. That's showing you the gas exchange. Now this is ARDS, the latter two rightward panels. Alveolar edema, this is the initial insult. That's the edema from very early on. When you get that insult and damage, you get this edema, pink edema fluid that comes into the airway, airspace rather, the alveolus. Compare and contrast normal to that. And you can see why patients with this might not oxygenate well now. Instead of air there, you have fluid. If this goes on, then you start to get exudates and hyaline membranes. This is several days later. And again, you can see, compare and contrast to normal, how this lung doesn't look like it's going to exchange gas in a normal fashion, and it does not. So what is happening here is you have fluid and increased numbers of cells and inflammatory markers, and you lose your surfactant, which helps you keep that alveolus open and stable. And so what happens is lungs become heavy, difficult to ventilate, difficult to oxygenate, and the alveoli collapse. We'll get more into this in a few moments. So positive index expiratory pressure, or pressure, helps to open those alveoli up and recruits those collapsed lung units. And by doing so, improves your gas exchange and your PO2, which tends to relieve hypoxemia. Now, while all ARDS lungs do require some PEEP, the degree of which, and let's say 5 would be typically a minimum, unusual for an ARDS patient to be on 5. And up into the 20s it can go. And again, it would be unusual for many patients to be up into the 20s, but there's a wide range. And what an individual patient needs and is best for them is going to depend on the extent of the damage and the phase of the damage, because there are several phases. We don't have time to get into that. What we need to remember, though, is the determination of how much PEEP they need is going to relate to their recruitability. How much lung you can open up with the PEEP is what I mean. So that's what I mean by recruitability. And that's going to vary between patients. This is just a paper from Dr. Gattinoni. At the top is panel B. This shows a patient with lower percentage of potentially recruitable lung. On the left panel is 5 centimeters of PEEP. Notice that in the basilar portions of the lung, there's white areas. That's collapsed lung, consolidated lung. When you go from 5 to 45 centimeters in the right panel, you'll notice there's not a lot of change. So there's not a lot of recruitable lung in this particular patient. Go to C, the bottom panel. This is a higher percentage. Again, on 5 centimeters of water on the left side, you can see a lot of airspace and collapsed lung. Again, this is not good. But when you go from 5 to 45, notice how much better the lung gets. You've recruited lung. This patient's gas exchange is going to get a lot better, whereas the person at the top going from 5 to 45 is not going to get that much better. In fact, giving too much pressure to a patient who doesn't need it has a downside, a very significant downside. So the point here is you need to think about what the individual patient may need with respect to PEEP, which brings me to low tidal volume ventilation. So again, Dr. Gattinoni is the most important investigator here. He described using CT scans that ARDS lungs are not uniformly injured. You think by looking at a chest x-ray, they all look the same, but in fact, no. Some areas of the lung are a lot worse off than others. And in fact, in the ARDS lungs, there's a portion of lung, typically a small portion, that is nearly normal. And he termed that the baby lung. In other words, in this adult, they have a small portion of lung, like a baby's lung, that is fairly normal or nearly normal. So in ARDS, based on what I've shown you already, you need to understand that significant portions of lungs don't participate in gas exchange well. And those lung areas tend to be at the basilar, when the patient's lying on their back, and posterior, basilar at the bottom and back. And if you look at this CT scan image up in the right-hand corner, I'm just going to show you that with red. Those are areas of the lung. Again, I'm going to go flash it for you. Those are deeply opacified. They're not participating in gas exchange at all, really. Now, the smaller portion behaves in a nearly normal manner is the baby lung, and that's up here. It's, again, non-dependent or anti-gravitational. The gravity-dependent areas are the red. The part against gravity up at the top, those are blue. And that area has a fairly normal compliance, which means stiffness, so they're not stiff, that area. Fairly well aerated by the CT scan. Again, I'll pop it off for you again. Look how it looks normally, fairly normal, like it should be black. Now, the thing that's interesting is when you flip these patients from prone to supine, you put their stomach down to the back down, these areas change, which tells you one thing, that a lot of that change is due to edema or fluid in the lung that changes with gravity. And that's significant. So I want you to think about that as we go forward. So that baby lung, that little portion of the lung, does better when you give it a baby tidal volume or a lower tidal volume. The recommendation is to begin with a tidal volume that is 6 milliliters or cc's per kilogram of ideal body weight. So when you dose the tidal volume for these patients, you must measure the patient's height. You should not guess. It's easy. A ruler and a measuring tape is not high tech. You must measure the patient's height, and you want to begin with 6 mils per kilogram of ideal body weight. In a patient with established ARDS, if you give them a smaller tidal volume, this is a landmark trial from the ARDS network 20 years ago now, giving them a lower tidal volume, and again, if you look at the graph on the right, this is survival. You give them a lower tidal volume, 6 cc's in this case, the light blue, that survival is substantially better, statistically and clinically meaningful, better than the higher tidal volume. And so that is a standard of care in ARDS, is to give lower tidal volumes. Again, 6 cc's is the starting place. The reason why it helps is because, if you think about it, it helps if you're going to ventilate a baby's lung. You don't want to give them adult tidal volume. You blow it out and injure it. So you want to give them a baby, a smaller tidal volume, and that's the basic idea. So I'm going to open up with another little concept here. So we've talked about ARDS, what it is. We've talked about PEEP, why we give it. And we've talked about the baby lung and giving a smaller tidal volume. Now I'm going to talk about thoracic cage and limitation of the lung and the regionality of lungs problems in ARDS. So as you're looking at the screen, you should see on the left a posterior chest CT, a chest CT at a coronal cut, looking at the posterior aspects of the lung. Then you have a cylinder. We'll get to that. Then you have an explanted lung and a patient who didn't do so well, okay? So the point of maximal constraint to the limitation of this lung expansion is, as we've already seen, it's in the posterior and basal portions of the lung. And what is also in the basal portions of the lung is the posterior ribs in the spine, and they are rigid, especially when you compare them to the anterior portion of the chest. So you're sitting there, no one's around, you can push on your xiphoid process in your lower ribs, and notice in your upper abdomen, notice you can push in a little bit. They're compressible. Now put your hands to the back and push on your spine and your posterior ribs. Can you push in a lot? If you can, you've got a problem. You should be rigid back there. That becomes important. So now going back to our figures, if we take a look at that lung, that explanted lung, and look at the chest has this, looks like a cylinder. I popped the blue in, that's about a cylinder. And then when I pop in the next one, that lung looks like a cone. So then, the lung is in the chest, right? We all agree with that. So we take a cone and we put it in a cylinder, where's the pinch point? Well, the pinch point is at the bottom. The lung at the bases of the lung have a lot more lung tissue than at the top or apex of the lung. When you put it in the chest, especially the posterior aspect, you get a pinch point. That pinch point is basilar or lower portions of the lung. I'm going to pop in another CT scans, both a axial cut on the left and a sagittal cut on the right. Again, we're going to pop in that lung. Look where it pinches. It pinches posteriorly. If you look at the spine, that's where the lung is going to touch, and that's going to be the constraint point. You look at the axial CT, here you see the heart, and again, these are basilar and posterior lung fields. So they're going to sit down against this spine and the posterior ribs that don't move much. And there's pressure from the edema down there, and just it basically keeps those lungs from opening. Moreover, notice where the heart is. The heart, I don't know if you can see my pointer here, the heart is here on this structure. Now, that heart is filled with fluid and actually has a weight. And where does that weight go? That weight also goes back against the posterior lungs. So when you look at all these things together, is it any wonder that the posterior lungs and the basal portions of the lungs have pressure and collapse and don't aerate well? And in fact, going back to our CT scan, if you look at any CT scan of someone with pretty severe or substantial ARDS, you're going to see that the infiltrates are going to be posterior and basal, and that's a problem. That's a problem. So then, what does that mean for us? Well, what it means is we can ventilate them in the prone position, and that actually reverses a lot of that. So this is from a paper, I took it from chest a few years ago. And basically it just shows you comparing the supine position in the upper panel versus the prone position in the lower panel. This pie-shaped thing basically shows you ventral lung at the top. There's a lot less ventral lung or anterior lung compared to posterior lung. And if you flip it around, put the patient with their abdomen down and their chest up, you get more lung that's up. And when it's up, because of gravity, it opens up more. Moreover, it tends to normalize or more equally aerate the lungs. Again, on the far right-hand side, I have these two graphicals. And basically what they just show you is the gas tissue ratio or the density of the lung. At the top is in their supine with their back down. And at the bottom is with their chest down. Notice how the graph is much more straight up, or the same density for the whole portion of the lung when they're prone as opposed to when they're supine. This kind of observation in a patient with especially the severe ARDS I've just shown you shows you that you can, because there's more volume of the lung posteriorly, that posterior portion of the lung is trapped against the posterior ribs and the spine. Flipping them into prone position can really help expand the lung and more normally or homogeneously aerate the lung. And when you more homogeneously aerate the lung, you tend to cause less damage with the ventilator. So all these aspects, including the cardiac compression, tends to favor ventilating these patients in the prone position. So there's this one small paper from China, again, looking at prone position in patients with COVID ARDS. This is just 12 patients, a retrospective study. it's in press actually, so it's been peer reviewed. So these patients had moderate to severe ARDS. The PF ratio is 130 on the day of intubation. Over here on the right is their data. The top panel is patients who were not prone. The bottom panel is patients who were prone. The first 5 did not get prone. The last 7 did. Prone positioning improved lung recruitment. We'll go over that in a moment. And gas exchange. The PF ratio increased from 120 to 182. So let's look. So the inverted triangle is a measurement that was made in the prone position. And what were they measuring? They developed a recruitability index. Because they didn't feel like they could take these patients to CT scanner because of COVID infection. So if the number was above 0.5 on these graphs, that was good. In other words, more recruitability. These lungs were more recruitable. If it was below that, they weren't recruitable. For the first 5 patients who were not prone, you only see 1 measurement above that 0.5 level. When they started to recruit these patients, a lot more of those parameters are above 0.5, and that's actually presumably quite good. It's a non-randomized controlled trial. It's just something to think about. 2 of the first 5 patients in this group died. None of the 7 who got prone died. Again, not reviewed, just something to think about. It has been done. Moreover, I'll just throw this out there because it's being done and we should know about it. There's been some interest, especially in places with not a lot of ventilators, of proning non-intubated patients. There's been reported success. These are not randomized controlled trials, something just to take home with you. Now, however, what I've told you about ARDS, all the things I've told you, that would be standard teaching about ARDS. However, Dr. Gattinoni, just recently, because he's Italian, and that's the epicenter, one of the epicenters of COVID-ARDS in the world, reported 16 patients who had, in contrast to typical ARDS, had nearly normal compliance and a high shunt fraction. And he said, then in these patients who had nearly normal compliance and a high shunt fraction, high levels of PEEP and proning didn't seem to help. And so that brings me to this another recent publication. Again, this is in press. Again, Dr. Gattinoni's group in Italy. He divided these patients into 2 phenotypes, basically. He called one phenotype type L and the other type H. So before we get to some of the details, type H phenotype is the usual ARDS I have just spent those slides telling you about. Type L is the one that is more particular, or seems to be more particular for COVID early on. And type L is probably an early injury. So in these patients, and this is the happy hypoxemic patient, why are they happy? Because they're not breathing too much, because their lungs are not stiff. It doesn't take a lot of work to breathe or expand their lungs, which is different from the usual case in ARDS. These patients have very low VQ ratios, or if they have shunt, it's presumably due to the pulmonary vasculature failing to vasoconstrict, as they said normally. Because they have normal compliance, they don't have much lung recruitability. And so there is an implication here from a therapeutic standpoint. And that is, giving these patients very high PEEP and proning them may or may not help. It should not be reflexive in all of these patients. You need to assess each one. You should start every person off with a lower tidal volume, but in some cases, he suggested you might want to liberalize the tidal volume a little bit in some of these patients. That's what he suggested. Type H is a typical ARDS, as we've been talking about. They also have low VQ ratios in shunt, but remember we talked about that. That's because they have this non-aerated atelectatic consolidated lung. These patients probably do have much better lung recruitability, so things like proning and high PEEP could be helpful, and certainly lower tidal volumes at 6 mils per kg is what you should do. Now, the thing to keep in mind is type L is probably an earlier lesion. It's not completely unique to COVID. In fact, I've seen patients like that. It's unusual. But if you manage them correctly, you want to keep them from going on to the H type, which is probably where most of the people die, in H type ARDS. Just the type L type, if you can keep them from going to H, that's probably good. And these are just my comments on reading the literature. So here are some reasonable initial vent settings for COVID-ARDS. Use the volume control mode. Start with a low tidal volume, 6 mils per kilogram. Again, you have to measure the patient's height. Can't guess. PEEP should be about 8 to 10 to begin with. You may need to rapidly escalate. You might not. You need to play it by ear and see how the patient's doing. You need to give them oxygen to obtain a SAT of 92 to 96%, just as we said before. You need to consider prone ventilation if you're having to escalate the high FiO2, like say 80% or more, and high PEEP is required. This was suggested by the American Thoracic Society Task Force. This was published last week or updated last week, and it's referenced below to you. 99% of their expert panel suggested a trial of prone ventilation if the patients are failing. But some of these interventions are not going to work as well for every patient, especially what we talked about, the different phenotypes, the type L versus the type H phenotypes of ARDS. And I'd strongly suggest if you're starting to think about escalating PEEPs and prone ventilation that you consult with an intensive care specialist. Now, just if you're interested, not for everyone, of course, but if you're interested, that recruitability index that was put forward by those investigators, there's a website, which I'm showing you here. There's a calculator which you can punch in the numbers, and there's actually some instructional videos. I looked through them, pretty good. This tool has not been formally studied, so it's just something to think about. But like everything in COVID ARDS, it's all changing. If a patient fails everything you can do with the ventilator, including prone ventilation, high PEEP, they should be considered for ECMO, because that's what you have left. So I'm going to say a few words about drug considerations of COVID and sum up. So one of the things most of you probably know is the COVID virus uses the ACE2 receptor to gain entry into cells that it infects. So there was initially a lot of concern whether in ACE inhibitors or angiotensin receptor blockers may increase the chance of getting sick or worsen the disease. The relevant professional societies include the Heart Failure Society, the American College of Cardiology, the American Heart Association recommend not stopping those medications if they've already been prescribed. Corticosteroids. As I think as alluded to, early use of corticosteroids have been correlated with a worse outcome. Say, for instance, asthma treatment. It's unclear whether they have a role in later phase ARDS, and that's true of COVID ARDS and ARDS in general. However, I will leave you with this. During the H1N1 influenza pandemic, corticosteroids during the first week of illness of ARDS was associated with worse outcomes, and there's a reference below. Chloroquine, hydroxychloroquine. So next week, it's my understanding there'll be a pharmacist talking about COVID-19 therapies, but I wanted to leave this with you because I think it might help a patient before that time. So hydroxychloroquine in particular has been widely used and it's possibly helpful. There's one randomized trial that I saw. Again, it's a preprint, it's not peer-reviewed. It was 62 COVID patients were randomized to hydroxychloroquine or not. It did suggest benefit. The American Thoracic Society, the same publication from the prior slide, their expert panels used the following language. They suggested using hydroxychloroquine on a, quote, case-by-case basis for hospitalized patients with COVID-19. 73% of the expert panel voted for it. The dose is 400 milligrams BID on day 1, followed by 200 milligrams BID times 4 days. You need to be careful regarding QT interval on the EKG and lengthening of that, especially if they're also on azithromycin. You need to just remember that. There are other therapies, which I'm not going to talk about, including antivirals, anti-IL-6, and convalescent sera. Hopefully you'll hear more about that. I'm very interested personally in the convalescent sera option. Hopefully that they'll become more available soon. So in summary, I want to read this and then I'll entertain questions. COVID-19 causes pneumonia with a minority of patients developing ARDS. That usually occurs in the second week of illness. There are risk factors, being older, comorbidities, especially hypertension, diabetes, and persistently high fever. These patients get hyperinflammatory. That's what leads them to ARDS and severe hypoxemia. So C-reactive protein is usually quite predictive in a high, and maybe IL-6 can help with that as well. ARDS is an injury to the alveolar capillary membrane. You get hypoxemic respiratory failure with low PO2s. When patients develop ARDS with COVID, they may get rapidly worse with relatively little dyspnea. Again, the happy hypoxemia, which we referred to the type L phenotype of ARDS because they're not stiff. The lungs aren't stiff yet. Hopefully they don't get stiff. You want to give supplemental oxygen, starting with nasal cannula. You might need to escalate, high flow, mask, or even intubate. Using high flow and even non-invasive has the potential to increase aerosols. So you got to balance the risk of that versus the patient's benefit. And again, that's very individualized. ARDS patients should typically be mechanically ventilated with lower tidal volume, 6 cc's or 6 milliliters per ideal body weight in kilograms. Higher PEEP will often be required in these patients. Prone ventilation should be tried for refractory hypoxemia, keeping in mind our discussions, and ECMO should be considered with failure of all ventilation strategies and their candidacy being good. Candidacy, I'm sorry. Lastly, COVID patients should, if you got them on, if they're on ACE inhibitors and ARBs and they're not hypotensive, they should continue. Hydroxychloroquine is suggested for hospitalized patients on a case-by-case basis. Now, again, that's the ATS language. And then corticosteroids should be avoided early in the course of COVID respiratory disease, pneumonia, ARDS. Later on, again, no one knows. You have to think about it. And that is all I have. Happy to accept questions.
Okay, I think questions have been rolling in as you were talking. There was one question about why does the patient need to be connected directly to the ventilator? Why can't we bag once the tube is in and the cuff is inflated if we have a viral filter in place?
Well, you can do it. It's just, again, the potential of aerosols is the issue. And so the hookups, and when you hook up change things, there's that potential. So again, I'm not going to say don't ever do it. I'm saying in the best circumstances, if you can get away with not doing that, so much the better. Every time you disconnect and reconnect, there's a risk of aerosol. And that's the basic answer.
There was a lot of discussion around differentiating type H from type L and how you might determine the compliance difference. Would you comment on that?
How would you do? Well, it's going to be a clinical judgment that the patient doesn't look, their x-ray and imaging, if you get an x-ray or get an imaging, they won't have all the collapse I showed on the standard ARDS images typically. They'll also not be, they won't, if you intubate them, you're going to find out, because then you're going to look at you can measure their compliance directly on the ventilator. That'd probably be the most helpful. And so a normal, in Dr. Gattinoni's patients, the normal respiratory compliance on a ventilator for the respiratory system is about 50 to 100. These patients had on average 52. That would be very unusual for the average ARDS patient. It's a clinical judgment that their oxygenation is dropping remarkably and they don't look that short of breath. And that's the reason, I think.
There was a question about using tocilizumab in these patients with high CRP and ferritin. Is that something that we're doing here?
Well, tocilizumab is an anti-IL-6 medication. There is some preliminary, basic reports of people using it with good effect. No one knows, honestly. I think there are some randomized controlled trials starting to be performed now. I don't know the answer to that, basically. And I think hopefully the pharmacist that's coming on next week will have some more opinions on that. But I think it's, if someone's, doing really poorly, I tend to have less of a threshold to do something. But again, no one knows the answer to that.
We also had an inquiry from someone who thought that they had been exposed to COVID about opportunities for antibody testing and donation of plasma.
Well, I know for a fact that they did administer convalescent sera at CB maybe a week or two ago. So the blood bank, I don't know if the programs that has been, if there's a program that has started here at UK yet. So I think that's what you look to. I don't know. I think those patients had their blood taken at the Kentucky Blood Center, but I don't know. I really don't know. I'm unaware of what's actually happening. But I know it's going on throughout the country, different places.
I am having technological difficulties. There we go. So this question is, so the cause of COVID-induced respiratory failure is ARDS. Am I thinking right? How soon
Yes.
that develops, and is it always with patients who have other comorbid conditions?
No, it's not always, but it is. They're much more likely to, age would be a risk factor, right? So an older person is going to be a risk factor, and obviously older people are more likely to have comorbidities. It's much more likely that a person with comorbidities, I don't think you're completely without risk if you don't have that. But yeah, I think so. So ARDS is what they get, yes. That causes them to go to the ICU and or be intubated.
How does high ferritin affect ARDS?
I don't know that high ferritin actually affects ARDS. I think it's a marker for high systemic inflammation because it's an acute phase reactant.
So given the worst outcomes with corticosteroids early in the course of COVID-19, what advice can you give us regarding patients with underlying COPD or asthma?
I think I'd try to avoid systemic corticosteroids if you could help it. Sometimes you can't, but you have to make a judgment on a case-by-case basis. But if you can reduce or eliminate systemic corticosteroids, especially early on in the course, I think that would be good. Are you talking about patients that are not infected yet or are already infected? I guess would be my follow-up to that.
I am just surmising from the question that it's about infected patients with asthma or COPD.
I would try to reduce or eliminate them if you could get away with it. But you have to use your judgment. If the patient's going to be intubated from, severe asthma exacerbation, you probably need to give them something.
What are your thoughts regarding awake proning?
Awake proning? I don't know much about it, but there is literature out there and it's accumulating evidence. I think there's a website called EMCrit, where there's a post from people from New York who've been using it. And they actually have, I was reading it this morning, as a matter of fact, and they actually have a little protocol you might want to consider about it. I think it's something to consider. I don't have the expertise because I've never done that, but I think you have to think about it, all kinds of options for all kinds of different patients, especially a patient you might not intubate for other reasons. Maybe that would be helpful.
There was a question here that one of our infectious disease docs actually answered. So for the person who, for folks who may be interested, because these flew by pretty quickly, someone asked if we were performing any trials at UK for remdesivir, and Dr. Leedy said, no, we're not one of those sites.
Okay.
There were also several folks commenting in the chat about where you can donate plasma, and that's the Kentucky Blood Center, and there were multiple folks who said that. What about ventilating in the upright position?
Well, I mean, you're talking about mechanical ventilation? I think in a patient that you're having real problems with hypoxemia despite mechanical ventilation, I think it's reasonable to try multiple different positions, because what you'll do is you can change ventilation perfusion ratios through the gravity effect on blood flowing through the lungs. That's a sort of a classic physiologic principle. And so, in ARDS patients of any type, sometimes you'll have patients that will be have a low PO2 or desaturated when you put their head down and put their head back up, they work better. Again, in that little podcast on or not a podcast rather, but that post on EMCrit, they talk about trying multiple different positions in a patient. These are not intubated patients, including the upright position, just moving them around.
So one of our hospitalists asked, many of these patients seem to be getting empiric community-acquired pneumonia treatment, including azithromycin. If we're using hydroxychloroquine, should we avoid other QTc prolonging medications like azithromycin?
Well, indeed, the QT prolongation, those are two drugs that can do it. Azithromycin has, beyond the antimicrobial effect, it has these pleiotropic immunomodulatory effect that we think in a lot of respiratory diseases may be beneficial. So again, I don't think there's any definitive literature to guide you. If a patient has a prolonged QTc, both drugs may be harmful if that's, prolongs it. However, if the QTc, you can measure it and it's okay on both, it may be beneficial. Again, we give a lot of azithromycin out to people with respiratory problems because we think it likely, I'm using the word likely, helps. It's case-by-case determination, I think.
One of our viewers asked, do you feel the pathophysiology of lung damage is due primarily to direct viral cytotoxicity or primarily due to cytokine storm / immune response?
Well, I think early on it's probably direct viral toxicity, but later on it's probably both. I'd say the cytokine storm is clearly rather pronounced, and I think you'd have to ascribe some of the pathophysiology to the cytokines themselves. I think as the course of COVID respiratory disease goes on, what I think some investigators from China showed is that their titer of viral units in their upper airway is much higher early on in the disease. And that tends to go away, and they tend to be much more prevalent in the lower respiratory tract later on. Now, I don't know of any specific data. I would encourage anybody who's listening, whether that titer of virus in the lower respiratory tree continues to rise or is stable or goes down when their cytokines come on. I think cytokines have to play a role. I think it's, they have to be part of it.
We got a question about, for institutions lacking ECMO, is there any benefit to giving a unit of packed red cells?
I don't know of any. You mean for the serum?
No, I think this was about if they're starting to deteriorate. I think there's been some people out there promoting giving blood transfusions, and whether there was any evidence behind that.
I don't know of anything about that. If they're not, especially if they're not severely anemic, I don't think I would change my practice on blood transfusions, especially since, there can be side effects like transfusion-related lung injury that can push people over the edge, and also volume overload. So I wouldn't necessarily do that.
There were some anecdotal observations about straying conservatively from low volume ventilation in patients with the L phenotype with success. Are we currently treating these patients with a different ventilation strategy?
I don't know that we are. I think Dr. Hatton at our institution is leading a guideline development for our treatment of COVID ARDS. And I think, I listened in on that. I think they're trying to bridge the gap, between what's known and what's likely to help and our current knowledge of ARDS in general. But there, as you say, there has been some suggestion that their tidal volumes might be liberalized, but I think important to say that the 6 cc's per kilo is our standard for ARDS. Dr. Gattinoni talked about liberalizing to maybe 6.5, 7, 7.5, nothing above 8. So if you're liberalizing and you're going, again, you should be careful, firstly, if you're thinking about liberalizing, but secondly, not above 8 in any instance, I don't think.
A couple more questions here. In the setting of negative COVID test, but imaging or other clinical findings are suggested of COVID, what is the best time to retest if indicated at all?
I would say probably after you get the results back, maybe a couple of days or so, and you might consider it. You can get a different type of test with the different testing characteristics that might be helpful. But I think as you suggested by that question is, initial testing, there'll be a 30% negative, that's what's reported from China. And specifically as disease goes along, the locus of the virus shedding shifts from the upper airway to the lower airway. So if you're continuing to test the upper airway secretions, you still may be negative. So especially if the patient gets intubated, testing lower respiratory secretions is the way to go if you are unclear of your diagnosis.
I had a question. Anyone comment on any comments on the suggestion of a hypercoagulable state in the COVID patients?
Is that for me or for others?
I think well, no one else answered it. I think it was for you, and just whether there's sort of any comment on the hypercoagulable state that COVID patients.
Well, I've read some papers on that, and certainly their D-dimers and fibrinogens are very high, and there's been some reports of DVT, et cetera. I don't know that, certainly these patients will qualify for standard DVT and prophylaxis. I'm not sure putting them on heparin is reasonable. I did read, okay, since we're getting into a little bit of the stranger and stranger, I did read a paper in China where these investigators actually tried a TPA on patients who were failing with COVID. It didn't seem to work. And in fact, when I looked at an autopsy paper, again, from China, that when you looked at the pulmonary vasculature, there wasn't a lot of microthrombi or anything that would be unusual for standard ARDS. So I think heparinizing or any other thing regarding their respiratory disease, unless they have an actual large, pulmonary embolism or DVT, probably not indicated, at least in my view.
All right, I'm going to ask one last question to get us in under the wire. There were questions about prophylactic intubation and its role in COVID-19.
Well, I guess when you say prophylactic, I have to ask you, how sick are they? Because you wouldn't intubate someone who's just sitting on some nasal oxygen. the question really is when, not if. So how long are you going to wait before you intubate someone? And that's an evolving question. Early on, a lot of people were saying, just intubate them once they have to go above 6 liters of oxygen. I'm not completely sure that that should be an across the board recommendation. I think if you have time to watch a patient, I think at this point in the right patient, high flow nasal in a negative pressure room might be a reasonable thing to do if the pace and progress of the hypoxemia is not extreme. Now, if they're just diving down, you can't do anything about it, sure, you intubate them. Again, these decisions are, I think, should be somewhat individualized. You don't want to, but flip side of that, you don't want to watch someone who's on maximum support of supplemental oxygen and then try to intubate them. These intubations are more difficult. So if you see it going that way, better to do it early. I know that's a hedge, but I'd have to see the patient basically.
And we have some more questions, but I think our time is up. So I think we're going to go ahead and end here. For anyone who is interested in reviewing it, it will be available on our site, but only for a few days. We have had requests to continue to have this up as some kind of enduring material, but as this is such an evolving topic, we have promised our speakers that we won't leave these things up for too long. But we do know that we filled so that some folks will have the opportunity to watch it over the weekend if they want to. And there are many congratulations coming across the chat on an excellent talk, Dr. Morehead. Thank you very much.
Oh, well, that's nice. I hope everyone stays well.